first day, filled with insightful discussion. Today, we also have an engaging lineup of sessions and speakers. So first, we will call for opening Quran by Mr. Hamza. So first.
بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد.
And thank you, Hamza. And now we will call Professor Chinchili for speech or opinion.
Morning, everyone. I'm Jinyi Chen from Taipei Medical University Fang Hospital. Welcome you come to our second day of our multi-specialty conference. This morning's section will focus on trauma, medical education, and an NCD discussion. So welcome everyone, and we will introduce our first speaker, Dr. Abu Hamid.
I hope I can start. Okay. Firstly, my name is Dr. Abdul Hamid. I work as a senior researcher in Hargeisa Group Hospital. Today in presentation, I will briefly talk about the current situation in Somaliland neurosurgery. Generally, global neurosurgery is an area of clinical practice, research, advocacy, and healthcare system innovation that seeks to address global healthcare by applying the tools of public health to the development of neurosurgery in general. This presentation provides a picture of the current state of neurosurgery in Somaliland and land whose social, political, and economic context is unique in Africa. Yet the presentation of the struggle for healthcare inequality in many post-mental settings. I will provide briefly biography status of actors in Somaliland neurosurgery, an overview of the current state of neurosurgery care delivery and first step toward capacity building initiatives. In conclusion, is a recommendation to guide the international neurosurgery community in future contribution and collaboration in Somaliland. Okay, the current status of healthcare in Somaliland and key actors is as follows. In briefly, according to the last 2022 report of Somaliland's public health sector remains regulated under government. In addition to the few private sectors institutions, active participants include in the international NGOs like United Nations, WHO, UNICEF. Also, there is also non-governmental organizations such as Save the Children, but all taken together, these groups provide most health services in the country, much emphasis on primary health care, maternity care, and child health. Significant gaps exist in surgical care capacity, including facilities in workforce, infrastructure, equipment, and service provision. According to Somaliland, government does not have access to development loans through the standard international banking mechanisms, making the government weaker than civil society. That means the civil society have much more investment than government in the health system. Currently, health care facilities include controlled by government, one national referral hospital in Hargeisa, one national maternity health care, and 5 regional referral hospitals, 3 district hospitals. According to the neurosurgery in Somaliland, neurosurgery epidemiology, there has never been epidemiological appraisal of Somaliland neurological and neurosurgical disease abandon. The relatively recent reduction of data collection systems and resources in the country further increase difficulty of surveying the incidence and prevalence of neurosurgical disease. Primarily, data from 2022 indicate that 35,000 cases of external trauma presented to Hargeisa Group Hospital, as the hospital is the hub for all these cases, and about 45,000 presented to the district hospitals for combined total of about 80,000. By my experience in Hargeisa Group Hospital, that cerebrovascular disease and neurotrauma are the leading contributors to the current neurosurgical disease abandonment. The day-to-day cases we manage primarily consist of emergency trauma and pediatric hydrocephalus and MMC repair. In generally Somaliland or in Hargeisa facilities, neurosurgery are Hargeisa Group Hospital, which is a public, and Amin Grand Hospital private, Royal Care private, Haldor, Hargeisa Neurological Hospital, and Adam, which is especially for shunt and spine birth cases, and same minor in mass. In Hargeisa Group, the department we have started since in 2019, which is currently National Main Surgical Care Center. Facilities limited but covers all basic needs. Mortality is about less than 5% for facility capacity cases. This is the current procedures we do in Hargeisa Group Hospital Neurosurgery Department. On conclusion for my presentation, through joint efforts, global partners in neurosurgery might find in Somaliland a unique opportunity to design and implement systems that will save lives, prevent disability, and make lasting, impactful contribution, and all in cost-effective manner. That's all from me. I would like to thank you for you, and thank you very much.
Thank you. Thank you, Dr. Hamid. Is there any questions for Dr. Hamid?
And he has been, I think, pioneering and started this work in Hargeisa Group Hospital. Earlier, we didn't have any neurosurgery, but I think with his initiative and his courage, we have now this department. And they were doing, now they do routinely neurosurgery and I think open surgery. So they saved also money for our patients. And I think the department still lacks some of the equipment, essential equipment. And this we are thinking also to improve in the future. So thank you very much, Abdi.
Thank you. As I know, our previous president of the International Neurosurgical Society, the president, Professor Du, he told me that they found a foundation to support some of the country neurosurgeons will have the train in Taiwan. So maybe hopefully when we come back to Taipei, we can contact with Professor Du to figure out is any possible for them under the society to give some support to Somaliland, especially Hargeisa Group Hospital. Hopefully we can send some excellent neurosurgeon to be there, have a full train of the fellowship training. I hope so. I will do my best. Okay, thank you.
Thank you.
And our next speaker, and our director, Dr. Ahmed Umar Askar, director of Hargeisa Group Hospital. Topic on forensic in Somaliland, a specialty with pulmonology and forensics.
So, Professor Ming and all the colleagues here, good morning. It's a pleasure for me to participate in this workshop and this global better health activity. My subject will be forensic medicine practice in Somaliland. So this is an important area. Maybe we talk about neglected diseases. So we can say also forensic work. Maybe it's a neglected area in our country, but we are all the time thinking to improve the situation. This side is nice. So forensic here, can you حقيقة أسير شديك can you type little حقيقة أسيرها ويا شو يرى عنده ما في عناه ها yes بالك سيرة وريش بالك هوسة كهوسة ها yes بالك بس little close yeah
That's it?
okay also okay that's okay. So we can okay. So we can talk about the background. Generally, this discipline, forensic medicine, we have two terms. One is forensic medicine, the other is jurisprudence. These two are used in the practice of law and medicine. So these two terms are not synonymous. They have some difference. Forensic medicine is also used as a term. It can be termed as legal medicine and relates to the application of medical knowledge for the dispensation of justice in court of law. This subject teaches man how to apply medical knowledge in solving and clarifying legal problems or issues. This necessitates examination of victims, accused persons, complainants, defendants, respondents, and different activities by medical experts in relation to some criminal or civil case. Medical jurisprudence means legal aspects of practice of medicine. So this deals with practice of medicine involves certain risks to the society. If the medical practitioner is negligent towards his patients or uses his practice in unlawful or unethical way, then the situation will be jurisprudence, and this will be brought to a court, legal court. Practice of medicine is guided by some codes, ethics, legislations, which we learn from medical jurisprudence. History, I can go a little closer because this is very small. The present days, all over the world, dispensation of justice through legal system has become more dependent on medical science. Law-medicine relations is traced as early as 400 to 300 BC, or in Egypt, and around 3000 BC, the chief physician used to be the chief justice too. Marka dhakhtarkun baa ahaa ninka isagu sharcigana haya. Hippocrates talked about medical ethics and wound and fatality. In ancient Persia, induced abortion was considered as a serious crime. In the 15th and 16th century, Italy and France showed much progress in the use of medical knowledge for legal purposes. During the 19th century, in Europe and the USA, the pioneers in many fields of forensic medicine, Trudillo, John Bagan, John Gleister, and Hamilton, all these pioneers were the founders of this discipline. Islamic Sharia discipline You know Islamic Sharia discipline, the diya for injuries and homicide diya. The Islamic scholars evaluate injuries and calculate the cost in camel value. So Islam was also earlier. So in the Islamic Sharia, the scholars, they know exactly how to evaluate any injuries, any deaths. This is now. In 1935, updated ordinance restricted the use of narcotics. The first law in Somaliland was introduced by the British in the 19th beginning of 19th century, and it is this book. And at least this book restricted list of narcotics. After the World War, the British improved the healthcare and also the education, and modern hospitals were built in many of the districts in Somaliland. And from these days, forensic medicine was introduced in Somaliland Health Service. Forensic in the Somaliland setting, if we talk about Somaliland, we can say the earliest forensic doctors were the faradin. Faradinku waxa weeyaan waa odayaasha dhaqanka. Marka usually the faradin traditionally were orthopedic surgeons, and they used it to reduce fractures and also to increase the skin or to remove depressed bones, and even to remove brain hematoma. So these were the earliest doctors for Somalis traditionally. And if somebody inflicts an injury to another person, it was solved in the traditional hair, which is between the Somalis. And the person who is responsible will pay the cost of the traditional cost doctor, and also will be responsible for the food and care of the injured person. The Qadi will later evaluate the wound and will decide how many camels to be paid to the complainant. The British administration has introduced the first legal acts and on medical issues. So the first Somali Protectorate Ordinance, Volume 1 is this one, was introduced in the 19th century early beginning, and especially in this book, the law ordered British registration and deaths in Somaliland. So every district, they should register any deaths or any child who is born. In this also, they restricted the sale of alcohol to the local people. So at least that was also a health part of that. In 1935, this was updated, and this restricted, the new ordinance restricted the use of narcotics or the sale or the importation. After the Second World War, British were more involved in improving the healthcare and especially education, and they built many of the hospitals, mortuary rooms, and from these days, forensic was introduced in Somaliland. We have one problem in Somaliland after the Civil War, and this is the major forensic examination in which experts participated, especially in Hargeisa. And this is what happened in Hargeisa in 1988. In Somaliland, there was a major event after the end of 1988 Civil War. Many people were killed. The people returned from the refugee camps, And then they found their cities destroyed, their homes destroyed, buildings were without roofs, doors, windows. But worse was the discovery of mass graves. And in Hargeisa, mass graves were in 3 sites. In the south of the city, one was called the Barka. If you go near the main British military camp, which is near the early, that was that was an early milk factory. And then there were also Malka Durduro, which is also to the south and west of the city. There was the evidence of genocide and atrocities of the military regime of these days. The issue of the mass graves got international concern, and the Office of the United Nations High Commissioner for Human Rights sent a team of forensic anthropologists. The team were from international organization, the Physicians for Human Rights. And actually, the team who were doing this was, the team examined 92 to 116 graves, and there they reported, made clear, the people died from traumatic injuries. They were wearing their clothes. They were tied together in ropes. The graves were digged with earth machine, moving machines. So when they were burying, they were using machines to excavating the land and then putting the bodies. Somaliland doctors participated from the forensic examination. This event marks the first international forensic examination in Somaliland. But still, the people who were responsible for these atrocities and genocides are still at large, and the dead are waiting for justice. I think forensic services in Hargeisa Group Hospital. For Hargeisa Group Hospital, the Somaliland Penal Code, which is also here, Xeerka Ciqaabta, Somaliland. This is in Somali. And this was really the earlier British Penal Code. And then it was combined with the early Italian Penal Code. So it became the Somali Penal Code. And then later, now it is with some amendments, Somaliland Penal Code. So it is the Attorney General, and it's authorized to request for forensic examination, also medical doctors to respond to any order from the court of law to come, also for jurisprudence, to answer legal issues that the court may ask him to answer. Any expert should be answering this request. Hargeisa Group, as the national hospital, has the obligation to respond to any forensic examination requested by the Attorney General or by the court of law, and also answer jurisprudence in any of the national courts. Medical legal services, usually what we are doing is sexual offenses, post-mortem examinations, DNA for families and children for legal issues, injuries, medical malpractice, alcohol abuse, pregnancy and abortion, agrochemical poisons or any other poisoning, drugs of dependence and abuse, mental health. Also, a lot of injuries are coming from burns, from car accidents. So these are what we are actually doing. The cause of death by post-mortem examination, I have evaluated some of the years, and the findings of post-mortem examination will give important data on the trend of different major causes of death in any country. So the data from the post-mortem examination was evaluated for the years 2015, 18. I think this is this is not right. This is 201 and 202. You will see later. They showed the trend of major causes of death in these years. There was no marked decline on major causes of death, e.g. road traffic accident, gunshots. This will be more serious intervention, need more serious intervention to address the major causes of death in Somaliland. So there are many preventable, I think, causes of death here. There have been a great improvement of roads and policies, but all these measures, even the new roads contributed to high speed and even increased serious car accidents. So this is some data, and by year, this is 2015. So we can see the road traffic accident is the highest. It is the highest. You can see 63 out of 280. And then we have gunshot, which is also leading. Another leading is the other problems. That is homicide. HC is homicide. That comes from usually sharp weapons, blunt weapons, violence. So it's also very high. Then we have infanticide. Maybe a child just dead will be brought or usually come to the hospital also for examinations. And this is also really sad, but there are these cases. Natural death, also, they sometimes quarrel between, for any reason, somebody dies in a hotel and they say he's poisoned, or dies in home, then they bring to us, then we find they have natural death. Other accidents are burns, drowning, also work-related accidents. So building constructions, these also. This is the same. I think I don't explain much. You see road traffic accident is very high. Also gunshot is a level. And then homicide is 23. And we can see infanticide here this year was less. But natural, also other accidents were there. This is also, I think this is 2022. And this is very high also. Road traffic accident, 88. And I will show you, this is also 2022. And you see the road traffic accident, 60 of the cases. Let me see the, we don't have the gunshot. Yes. Down, yeah. Gunshot, yes, 8 cases, and stab wound and others are still there. This is how we can analyze this data, because cause of death by mortem examination, the findings of mortem examination is, we say it can give important information and different major causes of death in any country. We have now collected from 2015, 2016, 2021, 2022. We show the trend, and here the number of deaths from road traffic in 2015 was 63, 49% were road traffic accidents. In 2015, also I think the number was high. Then here we have 2015, and you see also here 63, 40%, and 60%, that's here, is road traffic accident, 2015, 63, 49%, 60 cases, 59% in 2016, and 88, 57% in 2021, and 60%, 57% in 2022. The gunshot trend is also here. So we see 2015, we have 11% of the cases from gunshot, and then 2016, 7% of the cases. And here also we have 8% in 2022. So I think the trend has not changed. Maybe the cases, in some of the years, the number of cases are lower. So maybe this shows that it's not really, nothing has changed maybe from these times. The decline gunshot is also still there, and no major decline has been seen all these years. Homicide cases were from stab wound and blunt weapons, and these are also, you can see they are 18%, 17%, 12%, 11%. There's no major difference. Infanticide were 6 cases per year. Only in 1 year there are less cases. We have other problems. For example, mortuary and equipment infrastructures for and supplies. That's one, I think, challenge. Mortuary infrastructure building belongs to the old days of the British time. We have one room there, and this room was built in that year, in 1953. Few hospital mortuary rooms are equipped with mortuary refrigerators. That's countrywide. Perhaps some of the districts, they don't have even refrigerators. Autopsy examination, there is no adequate equipment. For example, no dissection equipment, no trolleys, no instruments, no furniture. So this is really one challenge where we are waiting to at least have autopsy rooms and mortuary services which are maybe to the international standard. We are working in that room which was built in 1953. It's a small stone building near the mortuary. So even the door we don't close sometimes. It's an old door, so we work there. Waxaa jira isna shortage of PP and safety measures in autopsy rooms, risk from infection exposure to the staff, to the others. This is important also to adhere to the ethics when you are doing autopsy. So there should adhere the staff and the doctors who are doing to the ethical issues. That's very important. There should be a legal request from a legal office or a court. You cannot do it by yourself. A consent must be received from the family or relatives of the person who is the dead person. And any part, tissues or organs you use for histology, for examinations, you should inform also, get the consent from the family. And also you should not use what is only necessary you have for the examination, but you cannot take part of the body or some of the organs. I think professional secret is very important. You don't expose this. You only provide in written form to the legal office. This is what happened in Hargeisa in 1988. These are the findings of the mass graves of that time. Thank you very much.
Studying for forensic medicine. So, yeah, but according to that, I have 3 points. First, in mainland China, ancient China, 300 years ago, we have the Dr. Song Ci. He's the first forensic doctor in that moment. Yeah, and he wrote a book to introduce the following doctor to how to do well for the mortuary, for the forensic investigation. And so this, I see this is a reporting table from the 2022. So compared to the previously, quite different, much more detailed item to the homicide also for the traumatic injury. Yeah, okay. This is kind of improvement because with the doctor go to investigation, autopsy, and then the cause of death, the injury, much more in detail. So the classification is very wonderful. So I have one question: is for in Taiwan, usually the older patient pass away, the family would need to acquire for the death certificate for them, and then can go to for the rest of the treatment for that. So how about the death certificate from in Hargeisa? It's by any doctor can certificate for their patient if they passed away, or need to be by Dr. Askar, certificate the forensic doctor to do this way. Depending on the cause, maybe on nature, something like that. So the death certificate, anybody can allow it to be for that. Thank you.
Usually, here in Somaliland, for example, we don't have a registration system for all who die or they are died. There is no notification. So it's not compulsory that we notify any office or any as a registration, because this perhaps will come with the now health information system that you are supporting us. Perhaps we will have a better also knowledge who died in the hospital and how many. Exactly, we know exactly all the deaths that happened in the hospital in our old system and the health information system. Any doctor can declare a person dead, because usually the family, they don't need certificates. They will take when he dies in the ward, the doctor will confirm to them and say this died. And then he will put in the register that this case died. So if we need later information or certificate, we can trace from the register. There are also death certificates which are needed for the families. And this is especially for orphanage. So children whom their father died, they need sometimes that the father is dead because some organization is supporting them, and they need that. Also for legal system, for inheritance, the family now need that they have their own, what they have inherited, so they have to divide. And this also we can. And this certificate, it's only the director who can sign. So this goes to legal things, and it should not be signed by anyone. So that's how we do it.
Our next speaker, Dr. Wu from Taiwan, for management of trauma in Taiwan.
Okay, hi. I'm Dr. Cloud Wu from Taiwan, and I'm working with ER and ICU in Hargeisa Group Hospital. And my topic today is about management of trauma patient in Taiwan emergency department. I know every one of you, or most of the doctors, know how to manage trauma patient, and it's based on ATLS, right? ABCDE, primary survey and secondary survey. But there are still some tips. So I know there are some easy part, but there are some tips about the ATLS and ABCDE, and I'm going to show you. Okay, so we're doing step by step. This is how we train our residents in Taiwan, okay? And from the beginning, there are preparation. Next. Okay, we have, every time we go to a shift, a day shift or night shift, we have to know the equipment that we have, and we have to be prepared ourselves that we're going to assess a trauma patient in every minute because we're in ER, right? So we have to be prepared ourselves and the team. We have to know how much energy our ER has. So we have to know that how many staffs and how many beds, and the situation now. Are we capable of dealing with 1 or 2 or 3 major trauma? Okay, next. So, pre-hospital and field triage is, in these cases, we're going to activate the trauma team before the patient comes to the hospital, because we have an EMT system, so they will tell us, this is a patient maybe fall from high places or a gunshot patient. So we have to activate the trauma team before the patient arrives. So we will tell, and by assess the patient with GCS and vital sign and injury site and type. Okay, maybe penetrating or a crushed patient or a blunt trauma. And then open, close, or amputation. These are the criteria that we're going to initiate the trauma team. And the mechanism maybe fall from high places or a high energy trauma like a highway car crash or car accident, or a gunshot wound and a stabbing wound. It's specific group like elder, children, or pregnancy. We have to activate trauma team first before they come to the ER. Next. So this is the triage that when big disaster happened, okay? Because when big disaster happened, we don't have much time to triage the patient like we used to do in ER. So we use a START, simple triage and rapid treatment, okay? There are 4 types. Because usually in Taiwan we have 5 categories of the triage. But here we only have 4 types. The black one is deceased. We don't do anything because we have to save the energy for the wounded patient. And the green one, we don't do everything. We let them walk to the hospital or get to the hospital by themselves. So we are dealing with the red ones. Okay, the red ones is the breathing rate is over 30, and then the capillary refill is over 2 seconds or no radial pulse. And then the D is cannot follow commands. And if it's a yellow, not green, red, or black, then it's a yellow. Okay, next. Next is a flow. So all walking wounded, no matter if you have a pneumothorax, maybe you have a pneumothorax, but you can still walk. That's a green. But if you are having a femoral fracture, you cannot walk, then you are not a green. It's based on if you can walk or not. And then if there is no respiration, then we will open the airway. If it's recover the respiration and the heart rate, then we will assume it's red. But if not, then we will see him as a disease and it's a black. Then we differentiate if there is the respiratory rate or the perfusion and the commands. Can the patient follow by commands? So that's the red. Okay, next. So before, that's the field triage. It's happened when the big disaster happened, and you have a lot of wounded patients. Okay, maybe over 10 or over 30. Okay, because we have earthquakes and typhoons and a lot of disasters in Taiwan, so we have many experience. So the triage, this is happened when the patient comes to the ER, and then we are basically based on the ABC. The A is the airway, breathing, and the circulation. Okay, next. So this is the flow. This is when we activate the trauma team. Okay, and before we have the GCS vital sign and the injury type and site and the specific groups, and then the energy of the trauma. Okay, next. So we're going to ABCDE, how we manage it. Okay, before we manage it, we have a lot of things to prepare, and we have to do the triage because there are all kinds of triage, and you have to know when to use different triage. And then we doing the ABCD. I think these are very basic for everyone, so I'll do it quick. Okay, next. So before ABCD, we can use a 10-second assessment. We ask the patient, what's your name and what happened? If the patient can answer clearly, then the patient ABC and even D is not compromised. Because you can answer a question very clearly by your mouth, then you have no airway obstruction. And then your breathing is fair. And then the D, you can follow the command. So you can assess very soon. But there are still some tips about ABCD I will show you. So next. The airway is very easy. If we have to remove the foreign bodies. The foreign bodies including the foreign bodies and the fracture. maybe there are some skull-based fracture. Maybe you have a gunshot wound like yesterday. You have a skull-based fracture, then you will have some bones into your mouth. You have to clear it and then secure the airway. And before you secure the airway, always assume every patient have a C-spine injury. So if we have to maybe do the airway management, maybe we have to intubate, and if there is a difficulty intubation, then we can do a cricothyrotomy. So we will, okay, next. We will stable the C-spine. Okay, this is one of the skills to secure the C-spine. It's usually used by our EMTs in Taiwan, okay, not the doctors. The EMTs know how to do this, okay? You attach your hands to the shoulders and you clamp the hand by your arms. And then the other doctor or members, they can do maybe the intubation or maybe do the cricothyrotomy, okay? This is the time when you remove the neck collar. Okay, next. And then the breathing. The breathing, only one I have to emphasize, always care about the tension pneumothorax, okay? You assess if there is a jugular engorgement or absence of the breathing sound or a trachea deviation. These, you don't need the x-ray to confirm these, okay? If you have a tension pneumothorax, do the needle decompression, and then by the meantime, you call for the chest tube insertion. Okay, next. And then the circulation. Okay, circulation is that we're going to assess if there is any bleeding outside or inside. Okay, the breathing is, the breathing, we have to know in what stage, because there are all kinds of hemorrhage. Okay, there are 4 classes of hemorrhage. I will show you later. So if there is bleeding, then outside, we just direct compression. And then if it is inside, how do we examine it? So your hospital, the ER, they have the butterfly echo. So they can deal with it with the E-fast. Okay, not just fast now. We are doing E-fast, including the lungs. Okay, and I already told them, and every one of the training in my class, they know how to do it. Okay, and then to prevent hypovolemic shock, we will have the 2 large bore line. So the 2 large bore line is very essential, because you don't have 2 large bore line and you spend time to do the CVC, it's not going to use because you spend too much time. You have to do the 2 large bore line. And what is large bore line? Next. Large bore line, we have all kinds of the needle, the gauge, right? Next. So the 14 to 18, these are the large bore lines. So the patient come, you just give the patient 2 large bore line and give the patient all kinds of fluids, okay? The normal saline, we just give in 1 liter of the normal saline. Because you have 2 lines, you can give both of the lines, okay, at the same time. And then you call for the blood, okay? And the blood, next. We have to know that if there is a poor conscious and neck carotid artery, poor sensitive of the carotid artery, then you might have to do the CPR. And if there is the neck, you can feel the neck, then it's 50 to 60. And then if the dorsal pedis, you can feel it, it's over 90. Okay, next. So there are 4 classes of the hemorrhage. Okay, the blood loss is from class 1 to class 4. But always treat the patient before the class. What does that mean? If the patient is maybe hypotension now, it's a class 3, right? But we will treat it like a class 4 because he is going to the class 4 immediately. So we have to treat it before the class. Okay, next. And then there's a massive transfusion protocol. If there is a massive bleeding, no matter outside or inside, and the patient is starting to shock, or you see a lot of ascites in the abdomen by the echo, then you will start the massive transfusion protocol. That's MTP. And the definition is we give the patient pack RBCs 4 units in 1 hour. And then we keep going, keep giving, and then 10 units in first 24 hours. And then we also have to give the FFP and the platelets. Okay, so the rate is 1 and 1 and 1. Okay, this is the protocol. Okay, next. So we're using the EFAS, not just the four sites of the abdomen and the pericardial effusion, but also the lungs, because the sensitivity is very high. So we used to assess the lungs. Is there any pneumothorax or any fluids inside the lungs? Okay, next. And then the disability. The disability is easy because we're going to ask the patient questions and to see if the patient can follow the orders or answer the questions. And then we prevent the secondary brain injury by giving adequate oxygen and the fluids. Okay, next. So the E is exposure and environment. We have to address the patient. I know there are cultural differences between, because maybe the female patient is difficult to convince them that we need to remove all of the clothes immediately. But still, we have to pass the right knowledge, because if you don't remove all of the dress, then you cannot know if there are any other injury sites. Okay, because most of the patient maybe conscious change, they cannot tell you what exactly happened, and they don't know what injury site do they have. And then we have to avoid hypothermia. Okay, we are going to use the warm fluids to give the patient. Next. And then the monitors. After ABCDE, we have to adjust it, and then we do the ECG and the pulse oximeter, and then we consider Foley to see if the patient's output is fine, and then consider NG. But if there is a skull-base fracture risk, then we don't do the NG. Next. So this is the teamwork. We cannot do or deal with a trauma patient, a major trauma patient, by one or two or three staffs. Maybe we will have to 4 or 5. Okay, so this is how I train the trainees in my class. We have to form a team. Okay, and then everyone have to know, because the ABCDE is not separate and sequence. They are doing at the same time. You're doing A, I'm doing B, and everyone have to answer the orders. You will have one leader give the orders, and then others will answer the orders. Okay, I will do the A, I will do the B. I will check the C, and I will do the fast. Okay, so everyone have to answer, because in the beginning there are always a chaos, but after training, after the simulation, they can do very well now. Okay, next. And then it's a secondary assessment, head to toe, every hole. Okay, and then we do the X-ray, other image, and other exams. Okay, and then we complete the history. This is very important. We have to ask the family if the patient have any history. Okay, next. So this is the AMPO history. Everyone knows what AMPO is, right? So the A is for allergies, M is medications, current use, and then the past illness and pregnancy. And then there's the last meal, because maybe the patient will go to the OT, so we need to know the last meal. And then the events, environment related to the injury, because there are many chemistry trucks in Taiwan. So maybe the car accident is maybe bumped into a chemistry car. So maybe there are some chemistry drug exposure. So we have to check if the environment, what happened, and at the scene, the EMT saw other abnormalities. Okay, next. So we will count the injury severity score, the ISS. Why do we count this? Because we will predict how many death rates the patient have. Okay, next. So the ISS is based on the AIS. The AIS is in each sections, like you have head and neck, face, and then chest, abdomen, extremities, and external. And then they have points 1 to 5. And then we, next, we will sum it together, and then sum the squares, the top 3 squares. Okay, next. The IS is sum of 3 highest AIS, the squares. Okay, so the highest score is 75. So the trauma OCA is 75. Okay, next. And now we're going to talk about the penetration wound management. Okay, next. So the overview, even it's a penetration wound, we have to deal it like a ATOS. So we start from the ABCDE. Okay, every algorithm is based on the ABCDE. So next. There are stab wounds. Okay, the stab wounds, 1,500 people die from the stab wounds annually in United States. And then the mechanism of injury caused by the thrusting action of a pointed object like knife or broken bottle. The depth of the injury is usually greater than what you see and what you expect, and only remove the foreign body in a clean place, in a stereo place, okay, and a stable place, like before the OP. We don't usually remove it in the ER when we saw the patient. Okay, don't remove it, don't touch it. And we will stabilize the wound site. Okay, next. And then there is a gunshot wounds. So the gunshot wound is also a penetration wound. Okay, and then the mortality rate in the United States is 10.2 per 1 million adults. Okay. And then the mechanism of injury, the tissue is lacerated and crushed along the path of the bullet. And if, the different bullets will cause a different injury, okay? And then the level of injury is related to the energy of the bullet. Okay, and the dense organs like liver and bone absorb more energy than the soft organs, okay, like the intestine or the colon. Next. So we have neck, chest, abdominal, and pelvis, extremities. And then there are all kinds of injury that can happen. So you will keep that in mind. You have to assess, because maybe the patient in the chest, then I will know maybe there is a tension pneumothorax, hemothorax, or other like rib fracture and other injuries. Okay, so just keep in mind. Next. So this is the flow. I know this is a little bit vague, but it still tells the patient will start the A, B, C, D, E, okay? And we assess the airway, and then we assess the breathing and the circulation. And we see if there is which side. Because if it is upper, above the nipples, then I think that's the pure chest injury. But below the nipples, we have to assess, because the knife will go down like this or go up like this. We don't know. So we have to assume there is abdominal penetration. So including the diaphragm injuries. Okay, next. And then this is the abdominal injury. And then we have 3 pathways, like laparotomy, and then we have further diagnosis studies, like we do in the CT, and then maybe we just observe. But different to maybe if there is a peritoneal penetration, okay? And if there is some findings positive peritoneal penetration, we'll go to the OT. And if not, then we will observe. And always observe for 8 to 12 hours. You have to keep the patient in ER for 8 to 12 hours, because maybe there are minor laceration inside. And if the bleeding still keep going, we will have a secondary image. Okay, next. So we will examine if the patient alerts by the ABCDE, and if there is some free air in the image, then we will go to different pathways next. So there are 3 pathways, just like before. And then there are CP1, the local wound exploration. And then we will go to the OT if there is any like diaphragm injury. And then there are serial clinical exams for a duration 24 hours. And if it is a yes, then we will go to the diagnostic imaging, maybe the CT, and we will check how much injury does the patient have. Okay, next. And the diaphragm injury evaluation, the risk is higher on the left side, because the right side we have the liver to protect. And usually the patient is right-handed. Maybe the stab wound will be on the right side also. And then we will delay 8 to 12 hours to allow the serial exams. And then we will repeat delayed imaging before the patient leaves the hospital. Maybe you have to check again, maybe we might not do another CT, but maybe we can check by EFAS if there is any ascites inside. Okay, next. So the summary of today is trauma triad with simple triage and rapid treatment, A, B, C, D, E. I think everyone knows, but there are still some tips. And then the secondary survey, and then the ISA score, because we have to calculate the death rate, and then the penetrating wound management. Okay, that's for today. Thank you.
Consulted. However, we still find some of the patients they're still in unstable condition, even after second survey. So my question will be, who will decide to do the start the secondary survey when you finish all the primary survey during the first episode? If the patient come here, you do the first survey, of course, a lot of staff will do at the same time. However, must have one of the staff or the leader will decide who will do the secondary survey.
Okay, the secondary survey, because when the patient comes to the ER, before the patient comes to the ER, or at the time the patient comes to the ER, we will activate the trauma team. And then the trauma surgeon will come to the scene and see the patient with us. But mostly in Taiwan, we will do it mainly, deal with the patient, the management will mainly by ER staffs. So the ER will discuss with the surgeon if we're going to the CT or going to the OR. Yes, and then if there are some deviations of the opinion, we will ask second opinion. Maybe there is a chest trauma, then we will consult a chest trauma also. And if there is a brain injury, then we will call a neurosurgeon also. So there is not only just one-man decision. It's always this from the discussion.
So you mean that you will initiate the trauma brew whenever the patient fulfill the criteria of trauma, major trauma, and the trauma leader will take over this case in the ER. I mean,
I will not.
Of course, he will not do it by their own self. However, they should be the leader of the trauma management team, right? At the same time,
Because he will have the decision to make if the patient is going to OT now or not, or we do the secondary survey. Yes, because the primary management is always by the ER doctors.
Thank you. And then my second question will be the ED, we so-called the thoracotomy. As I know, it's not have the evidence to support that the open thoracotomy for cardiac massage in the ED is feasible or better than the routine cardiac massage. However, some of the patients really need to do the open thoracotomy in the ER. So what is your opinion?
There is only 2 patients. From our hospital established until now, there are only 2 patients thoracotomy in ER. One I saw it is tension cardiotamponade. Okay, it's a young guy and have a car crash, but he come to the ER with conscious. He's playing his cell phone, and then he crashed in the CT room. When you do the CT, we know he has some pericardial fluids inside, pericardial effusion inside. So we sent him to the CT, and he collapsed in the CT very soon. Okay, and then we consulted the surgeon in the beginning. The surgeon is in the ER. So when the surgeon saw the patient is CPR from the CT room to the ER, he decided to do the thoracotomy in the ER. Yeah.
بسم الله الرحمن الرحيم. intaanan bilaabin maxay ahayd toobigana ka hadlay waxaan ku yar dari lahaa 2 qodob oo casharkii hore dhakhtarku inoo present gareeyay. Marka ATLS-ka laga hadlayo, it's very important, and waxaa jira preparation-ka qof baa laga yaabaa inuu gaari kula dhaco isagoo xaafadoodii ka yimi maybe inuu burco ka yimi boorama ku socday markaa jidka dhexuu kula dhacaya familigiisii wixiisiba kama warqabaan waxaa laga yaabaa in 20 beeshan 30 beeshan hal mar isbitaalka lagu soo wada tuuro oo la wada keelo aan de familigiisii ka warqabin situationkooda kana lala socda marka preparationka isbitaalka lama soo inform gareeyo lagu oran maayo 20 beeshan baa kugu soo socda 30 beeshan baa kugu soo socda oo lagu soo dhex tuurayaa berigii hore waxaa jiray istabaha soo sheegi jiray laakiin still taas waa informal communication sax oo isbitaalka la soo sameeyo preparation u sameynaysaa ma jiro maxay ahayd talabaad qofka marka la soo qaadayo waxaa jira improper handling qofkii waxa laga yaabaa inaan si toos ah ambulance ma jiro airbus ambulance laguma soo qaadayo gaarigii caanaha oo wadada iska maraya qofkii waxa laga yaabaa dhabar ka jaban la soo dhex fadhiisanaya marka improper handle-kaasna waxa keenaa secondary damage way jiraan dad badan oo markii hore ay dhaawacmeen lagu hoodo shaqaynayay marka lagu soo gaarsiiyana paralysis lagu keenayo waxa soo dhan baa jira waxyaalaha qaar suurtagal inoo ma aha markasta waxa laga yaabaa inaad helayna collar marka waxa jiray training yar berdhow sameynay kartoonkan caadiga inta la gooyo ayaad ka sameynaysaa maxay na collar marka haddaad aragto qofkii oo gebigiisu tenderness iyo swelling iyo head injury iyo waxa leh cervical lama dhaqdhaqaajiyo waxa laga yaabaa inaad iyadana aad complete quadriplegia aad ka dhigto waxa kale jira maxay ahayd dhaqaatiirta especially ama shaqaalaha emergencies-ka waxyaalaha ugu muhiimsan waxa qofka BB-giisa la eega BB-giisuna BB-gu ma determine gareeyo qofku inuu shock ku jiro in kale ilaa uu loss gareeyo in ka badan 30% of his magaranaysa qofka 5 litir oo dhiiga ku jira ilaa 30% loss gareeyo mooy BB hoos ma dhacayo marka ay filmic shock leeyahay marka maxay ahayd toy qofka waliba special markuu dhalinyaro yahay inuu BB-gu dhaco waqti ba qaadanaysa calaamadaha ugu muhiimsan waxa weeye balaska markaad eegto waxa weeye balasku aad buu sareeya neurogenic shock iyo hypofilmic shock waxa lagu kala saaranaa balaska neurogenic shock qofku bareer ka dhig dhaqan kale iska jiro dadkeena waxa jira marka qof emergency la keeno waxyaalahan waxa kamid ah qofka aad ka qaylinaya ee hadlaya aad loogu shaqeeyo qofka hadduu dadka ku qayliyo oo yiraahdo dadkii shaqeynayay xageed ka dhacdeen halkan isaga lagu soo ururay loo shaqeynay laga yaabaa in la miskireeyo qof aan hadli karin oo kooma ku jiro grants marka ETLS waa very important course-kan waliba si repetitive inuu dhakhtarku iyo shaqaaluhu qaataan ayaa muhiim ah sorry my name is Dr. Ahmad Said. I'm an orthopedic surgeon in Hargeisa Group Hospital. So I will present you about how do we care patients with gunshots. For the last 6 months, there was like a huge number of cases with gunshots. There was some war, and I will show you our experience. How do we manage the cases? We didn't do any research still, but we are planning. We will show you some cases. How do you manage it? And even we have more cases. If you get interested, I will show you. Doing war surgery is different from elective surgeries. It's very different because in elective time, you have a time to prepare everything by yourself, and it's a bit comfortable. But doing in the war surgeries or gunshot cases is very difficult. The level of contamination is very high. The tissue of the level of tissue destruction is very big. Sometimes it will be very difficult for you to decide what to do. You may need a multidisciplinary team like plastic surgeon, vascular surgeon, general surgeon, orthopedic surgeon in one case, because single case may need like multiple procedures at one time. Besides that, you should have to look at so many things like not only medical ethics but also international humanitarian law. You should have to keep so many securities since you are working with military. And sometimes, you should have to understand the discipline of the military, right? So maybe the thing is, these two pictures is at Hargeisa Group Hospital, this Hassan. When you are doing like war surgeries, everything is rough and rush. Even you don't have a time to wash your hands when you are like eating. See? So you will be very busy. Here it's like elective cases. You have a time and fun. You can take selfie. Everything is prepared, clean. But in war surgery is like very difficult time. And sometimes even it will affect your decisions what to do. Sorry. You know, not only gunshot. If you are working like in a war, when you are doing like war surgery, you are not dealing only with wounds from the bullet. Also, there are like some other problems which you are dealing, like blunt trauma. When the military, when there is a fire, and they always drive the cars in a very high speed. So there was always car accidents. There is a collapsed buildings, bombs, and explosions. You will deal all these things, and blunt trauma is always neglected. If you have a patient with gunshot and there is a wound, you will concentrate all your mind with this wound, and you will forget so many blunt trauma. It's always neglected. The wound which we deal is always either from bullet or fragment. When it comes to bullet and fragment, always fragment is very difficult, according to in our culture. Because if there is a bullet fragment inside, maybe in the femur, and patient see his X-ray and there is a bullet fragment, they don't care. They will ask you first, are you able to remove this bullet fragment? If you even if you even fix the femur like very nice way, they will not appreciate unless you remove the bullet fragment. That's how we see. You know, there's too many different bullets, depending on the shape, internal structure, mass, velocity. All these things affect the wound potential of a patient. And like this one, always we deal with this one. It's called Dragnikov or Kalashnikov. So it's very big. You see in the war in Las Anot. So it causes like very destructive wound when it hits to someone. Like this patient, he came to us with distal femur fracture. As you can see, there's a bullet, big one. The distal femur is like, there's a multiple fracture. There is a wound at the distal femur. So if you put your finger at this wound, there will be very big cavity and hole. Yeah, so it's not only about a small wound. If you put your hand, it will go deep inside up to the bone. So you should have to clean all these things. Unless you remove this bullet, they will not trust you. So we did external fixation. We removed the bullet. Then we put external fixation. This was like 3 days back after the operation. And there was another X-ray. I didn't bring it, but now he's fine. He's walking by himself. Besides the wound, besides the gunshot wound, there was also blunt trauma, and there was huge elbow hematoma. And later on, we realized it because we were concentrated about the wound initially. You know, when the bullet hits to the patient, it creates a channel. So this wound channel, initially it is very small because of the velocity of the bullet. Then it goes around. Then it causes like large wound, temporary cavity, which is like large hole. Then it goes out. So it's like when the bullet hits first, the velocity is very high, so it passes easily. Then it wibbles around, it causes like large cavity, then it goes out. So, you know, when the bullet hits, the entry site is very small, but the exit site will depend on which stage that the bullet gets out. Like if the bullet hits and out from here, there will be very small wound. Then it will the exit site will be also very small. If it's bullet gets out from when it's in the temporary cavity, the bullet will have large exit wound. If it passes the large cavity and small cavity, he will have very small entry and large and small exit wound. So I will show you some examples over there. Like this is a case. You have a gunshot, and there is a massive destruction of the femur, as you can see it. We did operation. The wound was very small. The entry at the exit site was very small, but it causes large destruction. We did intramedullary nail. Then, after 45 days, he heals well. There's a good hip and knee flexion, and even he can stand and walk. After 3 months, he go back to his work. So the wound was very small. The entry site was very small, and the exit site was very small. And this is another patient. We have a gunshot wound. The entry site was very small. It was around there. Then the exit site was very large. We did debridement and irrigation. Then we put small key wire. There was another fracture on tibia. We put external fixation. The wound was very devastating. Finally, it goes like that. Now we put him skin graft, and it's feeling nice. So initially it was very difficult. There was large wound. The bone was destructed, and even it was exposed. Later on, we do like subsequent IND irrigation and debridement. Then we do skin grafting, and it's fine now. This is also another case. This case, you have a femur fracture. It has a femur fracture, sorry. The entry site was around here. The exit site was here. It was like pinpoint. Even we didn't notice the exit and entry site. But when the bullet hits, it causes large cavity, large tissue destruction. It destructs the bone, and there was large cavity at the femur site. We did IND. All the bones were like they got out when we open. This is the fragments of bone. We bring it together. We nail it. This was like after operation, all the bones like came together, and he was walking nicely. This was one of our patients. After 2 months, he got out and he was walking by his legs. And but our problem is like bullet fragments. When there's a fragment and when there's a fragment and it hits onto the soft tissue, either it go that direction, it will go large cavity, either it will go this direction. There will be very multiple fragments into the tissue, and patient and the family will make you like compulsory to remove these fragments. Sometimes it will be very difficult. Like this case, there is a multiple fragments of a bone, multiple fragments of bullet. The femur shaft was broken, and we removed the bullet. We put internal fixation, which is intramedullary nail. After 45 days, the bone is well healed. He can sit, he can walk, and it was like he can flex the hip, knee, and he can walk by himself. He go back to work. Sometimes the fragment is very small and it's very sharp, so it creates like very long journey of cavity. So if you try to remove this bullet fragment, even if you put large, artery force, you cannot reach it. It will be very difficult. Sometimes when the bullet hits from anterior, you should have to operate posteriorly because it will be more near on there. So, like this case, there's a bullet fragment. It hits from the lateral side, it goes into the medial side. There is a wound. So it was around the superficial femoral artery, and it was difficult for us to remove. So they bring all their families, why don't you remove this bullet fragment? They concern more about the bullet fragment. So we didn't remove it. After 2 months, we did traction, and after 2 months, the femur is well healed. Still the fragment is there. And every week he came to the OBD, and he was asking me about, one time, are you going to remove this bullet fragment? And it has nothing to do with the pain and stuff like that. This is another case. Whenever the bullet or fragment is intra-articular or at the joint, you should have to remove in that case. So this is a bullet fragment. We removed it. It was around femoral neck. You know, when you are doing an operation, the damage is beyond what you see. If you open the patient and see it, you know, there's a cavity. You know, there's a cavity. Around the cavity, there is a concussion, contusion site. So all the tissue are affected. So you should have to clean and debride all this dead tissue and contusion tissue. Then the healing will be very fast. Like this case, there was like a wound at the lateral side, gunshot wound. We debride it, we clean it. Later on, it closed by itself. So that's how we do. So the principles of gunshot wound management will flow. It's like we evaluate the wound, and we use score, an ICR score. The wound in centimeters, the level of contamination and stuff like that. Then we do early wound excision and irrigation and debridement. We take him to the OR. We debride the wound. We clean all the debris. We remove all the dirt tissue. Then we do adequate drainage if there's any pus and stuff like that. We do dressing at ward, like with normal saline and buffodinidine. We don't do the primary closure. Then we give antibiotic, anti-tetanus. We put external fixation, early range of motion. Then we put internal fixation after like 2 weeks or 4 weeks back. This is a number of cases we have done last 6 months, 350 cases of gunshot, and almost over 271 cases of bullet and bullet fragments for the last 6 months. You know, 25% was femur shaft fracture, almost open. 29% was open tibia fibula fracture. 12% was bullet fragment, and we removed it. And 4 our fractures was only 11%. And we did foot and ankle injuries 10%, according to these 350 patients, and shoulder cases in 5%. If we wanted like to correct, there are a lot of problems like delay of transport and stuff like that. If we correct the level and location of medical care, so many things will be corrected. Like the first spots, there should be first aid, like ABC, ATLS, collection point. We should have to transfer the patients earlier, because some patients they reach us like after 3 to 4 days without nothing. And we did a lot of amputations. I didn't present it on here, but there's a lot of amputations we did due to delay. There should be intermediate stage, like some hospitals should be able to do small things, then they should transfer it. And specialized hospital, like Hargeisa Group Hospital, should be like referral hospital. Only difficult cases should come in Hargeisa Group Hospital, otherwise there will be a problem. The other problem we have is a transport. Thank you.
Thank you very much, Dr. Ahmed. I think this, the orthopedic service of Hargeisa Group Hospital, maybe in 12 years ago, the situation was very, very difficult. And I think the services was not providing adequate care. I think many of the traumatic or fractures, we didn't have the capacity. But I think after also that, we improved it, because we got specialized doctors. And I think today, Ahmed and other colleagues, and also we are doing now, residents are here, resident doctors are also, and Ahmed and Abd Rashid, they are the leading trainers. So I think this area has been improving for the last 12 years. We are very thankful to our doctors and what they are doing. And I think we can further improve all other needed, maybe improve all the time with the support also of our colleagues from Taiwan. We can get any contribution also. So I think we will keep this good step forward. Thank you very much.
In terms of the rehabilitation program, do you have any facility to do rehab after those kind of orthopedic surgery? For example, the patient with joint stiffness or some complication after the operation. The second question will be, in this tough situation, if you really face some severe osteomyelitis cases, or the risk of infection will high, then compared to the civil situation.
Yeah. In rehabilitation, we have some, but still it's not adequate. Like last 6 months, we managed more than 400 cases, and the capacity of rehab center is not enough still. We do some. We do only increase in range of motion, partial weight bearing, some kind of exercise, but we don't use like rehabilitation about the machines. We don't have physiotherapy specialists, but we have a trained nurses and physio. So still there's a gap, and we feel some of the cases we operated, they develop joint contracture, and especially in military and surgeries, it's difficult for us to give order. If we tell them like you should have to do exercise, they will not obey, they will refuse it. So still physio and rehabilitation is our gap, but hope we will improve it.
So do we have the rehab specialty in Hargeisa group right now?
For physiotherapy?
Rehabilitation?
I think because generally I think rehabilitation, because Somaliland resources are very limited. So when they are recovered, usually we have two things for rehabilitation. One is the family support. So they will take care, and they will take them home and others. We have a small center for rehabilitation in the hospital, and this they can come while they are in the hospital. The other care is especially they will go to the military hospital, so they will stay there and they will be socially taken care. But still we have to develop the social system and social support for people who are injured and who are, so I think this takes, but generally in our culture it's the family who is supporting, so nobody is alone, and so they are there. Yeah.
When it comes to osteomyelitis and infection postoperatively, we try to reduce. There is some cases who develop osteomyelitis, but it's not for big cases. We do some steps to reduce sepsis and osteomyelitis. Initially, we try to do multiple debridements and irrigations. So before like 3 to 4 times, we do debridement, we do irrigation, we take the patient repeatedly into the OR. And family, they always think that we don't know nothing because we are taking the patient into the OR with multiple times. So they will ask you, today you take the patient into the OR, yeah, you didn't fix it. And we always told them like there was some kind of cause, and and the aim is like to avoid osteomyelitis because we can't treat osteomyelitis. After that, we put external fixation. After external fixation, we give small time for the patient. We call it honeymoon period. So in that period of 2 weeks, we remove the ex-fix and then we do internal fixation. The number of osteomyelitis, the number of infected cases we see still is like very limited. we try some steps to reduce it. Okay.
Hi, assalamu alaikum. And I was just asking, when you have somebody coming from an emergency case or a trauma case to the emergency, how long is the responding time for the orthopedic surgeon to be attending to the patient?
Okay. Thank you. There is in orthopedic department, it's a bit different from other departments. There is a resident program, and there is a available resident into the hospital. So whenever there is a new case, and within 30 minutes, other doctors, they don't touch it. When the trauma cases arrive at the emergency, they call us. There is a duty program. Residents are available on every time. So when they arrive, when the case arrives, within 20 minutes, we see the patient and we handle it. There are some kind of top emergency situations like septic arthritis, open fractures, dislocations. All these things we do overnight. And if the case arrives like even at the midnight, like septic arthritis, dislocation, and open fracture, we should have to do it. So that's it.
Thank you very much. We will start our next presentation. First, I would like to thank Taiwan Medical Mission and one from University in Taipei to attend this multi-specialty education. For me, I would like about tackling non-communicable disease in Somaliland. We are shifting on the other area. So, as we know, non-communicable diseases are very more. There are different non-communicable diseases, but in our setting, diabetic, hypertension, chronic lung diseases or heart diseases are very more. Even in the cancer, the prevalence is increasing for the last 10 years. So we will discuss how they can affect the community in the world and in our continent. As we know, the pattern of non-communicable diseases in low and middle income countries, around 41 million people die globally. Around 74% of that death is occurring in low income countries, including in Somaliland. 17 million people die from NCD clinic are aged less than 7 years. So which means 86 of these 17,000 deaths occur in low and middle income countries. So every second, there's not every minute or every day, in every second there is a 28 life death between the age of 30 or 70 that killed by the non-communicable disease, mainly diabetic or heart disease. So 25 of that 28 life death, it occurs in low and middle income countries. So it's very huge number that non-communicable diseases are killing in globally, particularly in low income countries. If we see this picture, it shows what's called disability adjusted of life years. So in the blue color, it's from birth up to before the NCD clinic or non-communicable disease. But when a patient became disabled due to the non-communicable diseases, we already calculated what's called a disability adjusted life year. So if we can prolong that time, the patient can work, the patient can produce economy. But if the patient became disabled within few years, like if he became renal failure or if he became amputation for the non-communicable disease, that's a problem for the nation, that's a problem for the family, and that's a problem for the patient. So see the adjusted quality. Patient is without treatment and patient is without treatment. There is the green line is those patients who take treatment, and the blue line is the patients who are not taking treatment. So there is a shadow between life years. So we can prolong the life if we can get improvement of well-established non-communicable disease. This is the leading cause of death in globally. Previously, cardiovascular disease was the leading cause of death, but nowadays even the malignancy became surprising for it. 74% For that, death in globally occurs due to the non-communicable disease, 74%. And there's another world problem in low and middle income countries. There's a challenge, we call it double burden, because previously in Somaliland or low income countries, communicable disease or infectious disease are more. But for the last 20 years, even the non-communicable disease became increasing. So there's a double burden. Both communicable and non-communicable are killing a lot of patients in our setting. And the other problem is, and that health system of low-income countries are not prepared for this change, for this demographic change, increasing of non-communicable disease. See the population growth. In Africa, there is a lot of population growth, but the population aging is low because there is a premature death compared to developing countries. So in our countries or in low-income countries, there is a lot of premature death caused by the non-communicable disease. That's the problem. So in our target, we have to increase the age to prevent the early death due to the non-communicable disease. If you see this picture, it's a study from 1950 up to 2010. If you see how it's decreasing in developing world, for example, in diabetic or disease of the heart, there's a much decreasing in the prevalence of non-communicable disease. But in our setting, that's the reverse. The prevalence is increasing because we have no well strategy to prevent the death and disability due to the non-communicable disease. This is a very important presentation, this table. The red color is non-communicable disease, the yellow color is injury, and the blue color is communicable or infectious disease. If you see this corner, this developing well, see, this developing well and this poor income countries. So in developing well, still there are strategy to prevent the death of communicable disease. And also they already eliminated the infectious one. But in low income countries, see this one. The non-communicable disease are increasing. Also there's a large burden for infectious disease. So this is the problem for both disease, infectious and non-communicable disease. What about this study shows in patients who take in a medication and the patients who is not taking medication, see the difference. For example, in patients with heart failure, if we give only single medication like carfidolol, if we give this medication, carfidolol, effectively and continuously, there is a mortality decrease of 65% compared to those who is not taking the medication. So if we continue follow-up clinic and give the patient for medication, even the mortality is significant. The mortality decrease is significant number from 65%. But that's such as a summary from the non-communicable disease in low and middle income countries. We will discuss a progressive report about the NCD clinic in Hargeisa Group Hospital. In brief history, Hargeisa Group Hospital NCD follow-up, it was first established in the whole country. This is the first type of establishment. We already started December 1st, 2022, in collaboration with the Minister of Health, Hargeisa Group Hospital, and Saha Group, Somaliland American Health Association. The objective is that we can start this clinic is to improve the patient care. We have a lot of patients who are diagnosed with diabetic, and few years or few months later, they develop complications like amputation or kidney failure or heart failure like that. So in order to improve our patients and our patient care, we have to make a follow-up clinic. Then we have to register the patient, then the patient will be continuously followed that clinic. Then we will see his medication, his counseling and all this. The other objective is to conduct research. If we get a good data, we can conduct researches about the prevalence and the common cause of death in non-communicable disease in Somalia. The third objective was to make Hargeisa Group Hospital NCD as a center of training. You have to train and